would now like to call upon our beloved teacher, Dr. Mishrikotkar sir.
I'll just finish off very fast. This is I'll be speaking about nerve pathologies. Nidhi has given very good demonstration of the normal anatomy. So these are nerve fibers containing axons, myelin sheaths, Schwann cells. They are grouped together to form fascicles, and loose connective tissues, containing elastic fibers and vessels. They are surrounding it. It is called the sheath perineurium, and thin septas arising from the perineurium that spreads into the fascicles surrounding every single nerve fiber. That is called as endoneurium, and all these are surrounded by the epineurium. And the ultrasound picture looks almost same as the cross-sectional image. So peripheral nerves has to be imaged because of the new advent of the newer ultrasound systems. We have 8 to 18 megahertz linear probes. Visualization of the peripheral nerve should be close to the skin surface or the known anatomic landmark, as Dr. Nidhi has shown. And they are seen as parallel hyperechoic lines with hyperechoic separations in between. In longitudinal sections, they look similar to the muscle tendon, but there is a difference. Muscle tendons have intermittent continuity, while the nerve fibers are directly in continuity. And in transverse section, it will be seen as bright dots, like it is called as honeycomb-like appearance. And in longitudinal section, it is called as cigar case or straw bundle appearance. This is a cross-sectional area of ultrasound image, and this is the longitudinal image of the same ultrasound. Adjacent muscle and muscle fibers and continuation fibers of the nerve fibers are seen over here. So this is a median nerve. Multiple fine dots are seen over here, and this is intermittent fibrillary pattern of the muscle. And the same in a longitudinal section, the nerve which is shown continuity and the muscle fibers over here. So what are the common nerve pathologies that we come across? The commonest is nerve injury, and then compression neuropathies, tumors, and infective. These we can definitely show on ultrasound. Nerve injury, depending upon the type of injury, is neuropraxia is minor injury where there is only compression or contusion of the nerve fibers, and good recovery is always there. Axonotomesis is the partial breakdown of the axons and valerian degeneration occurs, but because of the preservance of Schwann cells and endoneurium, regeneration is still possible. And in severe cases of neurotomesis, that is actual anatomical severance is there, so there will be injury to the Schwann cells and endoneurium. Most of the time it requires surgery. Whether depending upon the length of the injury, we can say whether it is nerve graft is required or only a local repair is done. That can be given on ultrasound. Ultrasound definitely gives information about which nerve is involved, at what level it is involved, the cause and the nature of the injury, and the degree of injury, that is type of injury, axonomesis, neurotomesis, or neuropraxia only. And definitely it will provide about the distance between the two stumps to decide the surgical management. So this is a case of neuropraxia where there is a edematous nerve fibers. This is the normal nerve, and this is injury at this level. So these are the edematous nerve fibers are seen over here. So this is a case again. There will be compression injury, and to some part of the nerve fibers are discontinued, but majority part of the nerve fibers are still continued. And this is a severe case where there is actual severance of the nerve fibers. This is the proximal end, and these are the distal end. These are the edematous nerve fibers over here, and this is complete cut off the nerve fibers. So this can be definitely given on ultrasound, and which may not be able to show it on a MRI. This is again many cases like compression injury, muscle injury is there, which is hematoma, and it is compressing the nerve. And this is the fag end. This is showing early neuroma formation. This is a neuroma. This is formed very well, and this is the proximal and the distal ends of the nerve fibers are seen, and you can actually give the distance so that the surgeon will decide about the local repair or the nerve graft to be done. This is in transverse section. This is edematous nerve fibers at the site of injury, and distally, as you see, this is a neuroma formation. This is a nerve, and this is a cut end of the nerve, and this is a neural formation. This is a compression injury because of a aneurysmal injury to the vessel, and that is compressing the median nerve over here. This is just a few days back we had his case. This patient was operated for fracture humerus, and nail plate was done, and recently he developed radial palsy. On ultrasound it was a huge hematoma-like structure, and this was the compressing the radial nerve over here, and this is the radial nerve which is seen over here, and this is large hematoma. And then we took the X-ray after seeing the ultrasound. We took the X-ray which is showing the fracture of the plate as well as the old fracture of the humerus. This is the fractured plate also, the nail plate, and this hematoma is compressing the nerve. Now coming to entrapment neuropathies, nerves, because of the compressible structures, while they pass through the fibroosseous ligaments, tunnels, they are compressed, and the commonest lesion is carpal tunnel syndrome, where the median nerve is compressed, and in ulnar nerve is compressed in Guyon's canal. Dr. Amit has very well demonstrated about the carpal tunnel and the Guyon's canal. So it is the commonest compression injury, and the cross-sectional area of 10 square millimeter is abnormal with abrupt narrowing distally is the diagnostic for the compression injury. So enlargement of more than 2 millimeters in cross-section should be always 100% conclusive of a carpal tunnel syndrome or any nerve compression pathologies. So in this case, this is a normal median nerve, and in this opposite side, this is a compression nerve, and this is proximal dilatation is seen over here. This is just comparison between both the sides, right and the left, and you can actually measure the distance. Then coming to infections, viral infections and leprosy are common. So this is a localized edematous ulnar nerve, and in longitudinal section you can see this is the edematous ulnar nerve at the posterior end of the posterior part of the ulna, and some fibers are still there which is continued. Now coming to nerve sheath tumors, which are very common. Schwannomas and neurofibromas are the common tumors. Schwannomas are usually eccentric along the long axis of the nerve fascicles, and neurofibromas, they are spindle shaped, and in the center the nerve fibers are seen. And on ultrasound color Doppler, schwannomas show some more vascularity as compared to neurofibroma, and schwannomas also have more cystic changes as compared to neurofibromas. So this is a large subclavian brachial plexus neuroma. This is the proximal end, and this is the neuroma formation over here. This is schwannoma form. And this is another case where there is a predominantly cystic lesion, eccentric, and it is compressing the nerve fibers. This is the SOL. This is the posterior tibial nerve. And we put the needle to have the diagnostic information, and it turned out to be schwannoma only. So advantages of ultrasound is it is inexpensive, it is widely available, there are no contraindications, it allows rapid and detailed imaging of the entire length of the major peripheral nerves, and always it can be compared on both sides. It is definitely superior to MRI because of its ability to have a dynamic study, and it can be moved from segment to segment, and comparison is always possible on both the sides. Thus, ultrasound is a useful modality in the evaluation of almost all the pathologies of the peripheral nerves. Just because of the lack of awareness about the potential of ultrasound images in the form that referring clinicians do not understand easily, and lack of expertise have led to MRI being favored over ultrasound in imaging of the nerves. But as people like Dr. Nidhi and Dr. Bipin sir are available, definitely it will change the scenario. And definitely in our country, with majority of population unable to afford a costly diagnostic test, ultrasound should be the most preferred modality. Zeidman et al. Have reported that ultrasound has a higher sensitivity and equivalent specificity as compared to MRI, and also detects multifocal nerve lesions better than MRI. They go on to say that ultrasound is the preferred initial modality in anatomic evaluation of suspected peripheral nerve lesions in ultrasound accessible regions, definitely. Making the referring clinicians aware of its possibilities, proper labeling of the images along with panoramic views, and adequate training of radiologists are definitely good steps in the right direction to overcome these drawbacks on ultrasound. Thank you very much.
Thank you, sir. That was an amazing lecture. We all split here and hope to see your smiling faces tomorrow morning at 9.